Okay, so the first topic is dysmenorrhea. So what happened in dysmenorrhea? You need to know the definition, what is primary and what is secondary. What is primary? Primary is basically recurrent, crampy, lower abdominal pain during menses in the absence of demonstrable disease. So there is no underlying disease that is causing this pain. So this is basically primary. But when there is an underlying disease going on, then it is basically secondary. So primary is differentiated. You need to know how to differentiate between primary and secondary. Primary is basically there is no underlying disease, but in secondary, pain during menses that can be attributable to an underlying disorders like adenomyosis, endometriosis, fibroids. We will read in detail in next topics. So etiology, you need to know what is primary. Primary is basically idiopathic. Secondary, there is differentiating like different diseases underlying it, adenomyosis, endometriosis, polyps, and anomalies. They don't particularly ask you kind of this question, but you need to know what comes in secondary and what comes in primary. Then comes the comparison of primary and secondary. So if you know this comparison, it is very easy for you to differentiate what is this particular disease and how you have to make the diagnosis. So features. Primary, what is primary? Primary is basically recurrent, crampy, lower abdominal pain that occurs during menses in the absence of demonstrable disease. So there's no disease going on, it's primary. But when there is an underlying disease, like similar features as primary, but with an underlying disorder that can account for the symptoms. But you need to, when there is like other than pain, there is other features coming along with it. You need to know, yeah, this is something particular disease going on underlying. So we need to know this is adenomyosis, this is endometriosis. Sign and symptoms are kind of same. So primary is basically colicky pain in the abdomen, radiating inner thighs, and bleeding and persisting for hours or days, and associated symptoms, nausea, vomiting, bowel habits, headaches, fatigue. So silent symptoms are very important for you to need to know, because these silent symptoms you need to find out in physical examination and in the making the diagnosis. If you know these silent symptoms, it is very easy for you to get to know what this disease is. Then in secondary, I'm just reading in the comparisons, so you get to know easily how you differentiate between them. So in secondary, what is the sign and symptoms? Same symptoms as primary, but along with it, there is other symptoms that is particularly giving you the diagnosis of adenomyosis, endometriosis. So they don't give you some symptoms of primary and ask you to make the diagnosis of adenomyosis. Obviously you cannot. So they will give you dyspareunia, abdominal bleeding, infertility. So with the basis of that, you get to know, yeah, this is secondary as well. Then diagnosis, how will you make the diagnosis? Like associated dyspareunia in the primary, abnormal bleeding, infertility, rule out underlying pelvic pathology, confirm cyclical nature of the pain, pelvic examination not required, indicated for the patients, not responding to therapy with the signs of organic pathology. But in the secondary, when you do bimanual examination, you find out adnexal tenderness, uterine tenderness, fixed and retroflexion, uterosacral nodularity, mass, and uterus. Ultrasound, laparoscopy, hysterectomy, and hysteroscopy may be necessary to establish the diagnosis. So it's very important. You get to do ultrasound, you find out fibroids. You get to do laparoscopy, you find out something polyp is there. In hysteroscopy, you might find out adenomyosis. So it is very important for in the secondary you do these investigations to confirm your diagnosis. You cannot either on the basis of symptoms just directly say, yeah, this is it. You need to do some investigations. And then vaginal and the cervical culture to rule out PID, pelvic inflammatory disease. Then treatment in the primary, you just need to give some painkillers. Start with the regular one, like giving some exercises, local heat. So usually we start from the low, and then we can go with the medications. If she said, yeah, I have already tried exercise and heat and everything, but it's nothing is working out, so you can prescribe NSAIDs. If she already said that I already used NSAIDs, now you have to jump into the CHC. So you have to go one by one. You cannot directly jump and say, oh, you can take CHC. It is very important. You need to know one by one what you need to start, when to switch into the next level, and when to come back. In the secondary, you need to make the diagnosis, and on the basis of the diagnosis, you will go to the treatment. Then comes endometriosis. It is very important topic and very exam favorite topic. The presence of the endometrial glands outside the uterine cavity and chronic conditions resolving along with the menopause. Etiology, what is basically not fully understood. So, there is not much etiology that is present. So, but still there is like four five theories, and etiology you need to just read it by yourself. Differential diagnosis may be chronic PID, acute self meningitis, and hemorrhagic corpus luteum, and ovarian neoplasm, ectopic pregnancy. I need to focus on this point that you need to know the differential diagnosis of each and every disease. Whatever disease you are reading, it is very, very important. You need to know the differential diagnosis, because once they give you some symptoms, if you don't know the differential diagnosis, how will you write? If they ask you write down 2 or 3 diagnoses, how will you write 3 diagnoses if you don't know that it is basically endometriosis, and now you are thinking what else should I write down? So you need to know the differential diagnosis is very important for every disease. Then comes epidemiology. Epidemiology is basically, it presents for 25 to 30 years, is very important, because how will you differentiate from endometriosis from adenomyosis? Adenomyosis comes in the later period of the time, but endometriosis comes in the earlier period of the time. Regress is after menopause. Family history is one of the very, very, very important. They definitely give you, if they want to know endometriosis, they will give you that family has some, his mother, sorry, her mother, her aunt, or somebody has it, like that. So 7 to 10% increased risk by if affected, and first degree relatives. Obstructive anomalies of the genital tract and nulliparity, age more than 25. So 4Ds of the endometriosis, what is that? It's very important to make the diagnosis. So you need to know all these 4, because in that scenario, they always give you these 4Ds. If not, at least they give you 3. Dysmenorrhea, dyspareunia, dyskaxia, dysuria. I hope you know what is the meaning of the dysmenorrhea, dyspareunia, dyskaxia. If not, you can read it from Google. So then comes the sites of occurrence. 60% is in ovaries and broad ligament, peritoneal fold, and peritoneal surface of the cul-de-sac, uterosacral ligament. So you need to know the important ones. Which one are important ones? Ovaries, broad ligament, folds, and then comes the different one. I don't know. Okay. So then comes the clinical features. Clinical features, okay. So it presents in 3 types. So either it can present with a lot of pain, it can present with the infertility, it can present with the mass. So it is not important they will present both of them. If they can present with the pain, you need to rule out endometriosis. Like she might present with you like cyclical symptoms due to growth and bleeding of the ectopic endometrium, usually precede menses and continue throughout the afterflow. Secondary dysmenorrhea, sacral back pain with the menses, and may usually becomes chronic, worsening perimenstrually, and deep dyspareunia. So in the bladder and bowel symptoms, it presents with the dysuria, hematuria, frequencies, diarrhea, constipation. So you need to remember all this by, if somebody asks you what is the pain feature that comes, so you need to know exactly what it is, because sometimes, it is very important. Infertility, like 30 to 40% of the patients with endometriosis will be infertile. So maybe infertility presents with that woman cannot get pregnant, so she came to you and you have to rule out endometriosis. So one of the diagnoses would be endometriosis. Then mass, ovarian mass, basically chocolate cyst. If somebody remember that chocolate cyst is present in the ovaries, so ovarian mass is one of the very important. It sometimes is symptomatic, but sometimes asymptomatic as well. So it can present in 3 forms: pain, infertility, and mass. Then is physical examination. Sometimes they give in the scenario, this is a physical presentation, tender nodularity of the uterus, the uterine ligament, and cul-de-sac on the recto-vaginal exam. Fixed retroversion of the uterus and firm fixed adnexal mass. Then comes the investigation. What are the investigations? So what happened here is, if somebody is coming with endometriosis, you need to start with the CH. You don't go for the present investigations. I would highly recommend if anybody can mute yourself. So then comes the endometriosis. Endometriosis basically take home points is very important on the side, this bar. It says that the history, even with a negative exam, should be considered adequate for the presumptive diagnosis. Then pain that is not primarily dysmenorrhea should be considered endometriosis until proven otherwise. So it is a very high likely statement that if a woman coming to you with the pain and there is no other features or stuff like that, this is not basically primary dysmenorrhea. So you have to think the first thing that will come to your mind should be endometriosis until proven otherwise. Until proven otherwise means that you have to do something to rule out. Like you do some investigation and you do find out this is not endometriosis, then you can say, yeah, this is not endometriosis. Otherwise, the first thing that comes to your mind should be endometriosis. So I hope that makes sense. This until proven otherwise statements are very, very common in the Toronto notes, and you need to know which one is written where. There's a lot of written in the general surgery, a lot written in like family medicine, surgery, emergency. So you need to know which ones are like until proven otherwise. Then comes the medical treatment is the mainstay of endometriosis. Somebody coming with the symptoms, you start with the treatment right away. So before doing this investigation, I'll jump into this table here. Suspected endometriosis. First line is CHC, progesterone alone. And if this fails, then comes to the second line or either go to laparoscopy on the choice of the patient or on the severity of the disease. You can do both. GnRH, agonist, and progesterone IUS. If both of them fails, then you can reconsider your diagnosis. Maybe this is not endometriosis. You need to think of something else. Chronic pelvic management and multidisciplinary support. So what happens here is, like I said, you can choose both. So what happened here is, if patient is coming to you, oh, I want to do investigations, you cannot give her GnRH or progesterone. You need to do laparoscopy, right? If that person is presenting with a lot of severe problems, you cannot jump into a laparoscopy. You need to give GnRH because you need to treat the symptoms first and then go for the investigations. I hope I'm making sense. Investigations, basically definitive diagnosis can be based on the direct visualization by doing laparoscopy, which is the gold standard. Biopsy and histology is very like unlikely done, but the first thing that if they ask you what investigation you will do is laparoscopy. Laparoscopy, what you will find, you can read all of this from here, so I'm not going in the detail. Then comes the treatment. Treatment is basically surgical confirmation of the disease is not applied. As I already said, you will directly jump into the management plan, like giving hormonal contraceptives, NSAIDs, first line, OCPs, Depo-Provera, progesterone, Mirena, IUS, and GnRH agonist. So one of the questions that I want to highlight here, and I want you to answer this in the group, is basically if somebody is coming with heavy menstrual bleeding, how will you treat that patient? Okay, we will discuss this later on. Then first line, second line, GnRH agonist, and then is danazol. Surgical is basically conservative laparoscopy using laser, electrocautery, laparotomy, ablation, hysterectomy, bilateral salpingo-oophorectomy. So it is dependent on the basis of the severity of the disease. What is that female presenting with? Then you have to choose according to that. If that person is presenting with the ovarian cyst, you will go for ovarian cystectomy. But if that person is presenting with a lot of, like, she has already been done with the pregnancy and now she doesn't want to go along with it and she wants to get rid of this problem as well, you can go for hysterectomy if she wants it, bilateral salpingo-oophorectomy. So best treatment that should be done after for the pregnancy is after doing laces of adhesions. You can ask the counsel the female that she can get pregnant right away. If the patient is not planning to become pregnant post-operatively, you have to stress ovulation by giving GnRH or danazol or whatsoever it is needed. I hope this is enough for endometriosis. I think you need to know the basics, the first line, then the second line, and the sign and symptoms, then investigations, and when to do when. It is very important what to do at when. Is like, the whole scenario changes according to the patient's preference, according to the symptoms and signs. So it is very important. You need to know line by line, like what comes first, then what comes second, what comes third. Okay, then adenomyosis, there's a lot of diseases where you start the treatment right away instead of doing investigations. So you need to know which one are those ones. Then comes adenomyosis. Adenomyosis is basically endometriosis interna. And then epidemiology, like 15% of people is more than 35, found in 20 to 40% of hysterectomy specimen. And it presents in mostly in the old female. Mostly asymptomatic, presents with a heavy bleeding and secondary dysmenorrhea, pelvic discomfort, dyspareunia, dyschexia, bulky, usually less than 14, Halban sign like tender, softened uterus, or premenstrual bimanual exam. So adenomyosis is extension of the uterus of the endometrial glands and stroma into the myometrium. So it goes all the way away. Final diagnosis of adenomyosis is based on the pathological finding, but predictably identified on MRI. So if they say, what are you going to do in this patient first? So you are going to do MRI. But if they say you have to, what is the investigation you will do to confirm your diagnosis? Then comes the pathological by doing MRI along with endometrial sampling. The investigation is basically either clinical diagnosis. You don't do a lot of investigations. If somebody is coming with heavy menstrual bleeding, you checked on the examination that it is bulky, you go for adenomyosis, you treat it right away. You don't have to do ultrasound or MRI. What are you going to look? Nothing, right? You cannot find anything. So, but still, unless if they want, oh, you need to do some investigation, what are you going to do? MRI. But if that the investigation particularly asks to make the diagnosis, then it would be endometrial sampling. But it's hardly done in the regular settings, because it's kind of expensive. It kind of, you have to think of those points as well. What is expensive, what is good for the patient, so on the basis of that. Then comes the treatment, because this patient have been having a lot of bleeding, so start with iron supplements, analgesics, NSAIDs, Mirena IUS, CHC, medroxyprogesterone, GnRH agonist, and danazole. So you have to do one by one. If that person is coming, iron is given, analgesics because of pain, and then Mirena IUS, right? Stop it right away. But if she said, I don't want IUS, I want something orally, so you have to do CHC. But it's like live, limited evidence. You can tell the patient, oh, this is limited evidence. Maybe it will not help you. But if she wants it, you have to give oral, okay? Then surgical, basically hysterectomy, treatment of the choice in a woman who has already done, childbearing age. Then comes the fibroid. Fibroid is kind of like that. Uh, it's very common in the black female and is very large and occurs in the earlier age. So it is basically what happens is in the pregnancy it affects a lot, and in the old menopause woman it affects a lot. So leiomyomata, fibroids, benign smooth muscle tumors of the uterus, most common gynecological tumor, and most common gynecological tumor and just a second. Okay. So benign. So on the side, it's written benign smooth muscle tumor of the uterus, most common gynecological tumor. Submucosal leiomyomata are the most common, which causes bleeding and infertility. Large fibroids can cause distressing bulk symptoms, because large is compressing the bladder and compressing the rectum as well. So might have constipation and might have the urine incontinence problems. So effect of the pregnancy on the fibroid is variable. Then comes the pathogenesis. You can read it by yourself. It's not like very difficult. So investigation, classification. You need to know the classification: intramural, submucosal, subserosal, and fibroids. If you don't remember the classification, it's totally fine. You can just write down fibroid. It will totally work out. But if they are giving you some specific symptoms from some specific, like they want you to rule out this is intramural, submucosal, they will give you those specifically specific symptoms, because they want to hear that word. They want to hear that you write submucosal. They're not going to tell you, oh, this is coming with a lot of bleeding, and they were expecting you, because anybody can tell this is fibroid, right? So they were asking you to write down submucosal fibroid. So it's not all the time, but most of the time when they are giving you those specific symptoms, you need to know the specific diagnosis. Until you don't know and you don't want to mess up, then yeah, you can play safe. But I'm not sure if that can give you a lot of marks. Then comes the clinical investigations. Asymptomatic, uterine bleeding. Asymptomatic is basically 60%. Birth symptoms, pressure symptoms, pelvic pressure, heaviness, girth, frequency, urgency. As I told you, they will cause the same pressure on the sides. Then comes pain, infertility, complications, malpresentation, cesarean. So it causes a lot of this. So you can read all of them. Mainly is basically asymptomatic. If that female is asymptomatic, you're not going to do anything. So there is no treatment needed until she asks for it. Because if she asks, oh, I have something in my belly, and I wanted the treatment, and you said there is no symptoms coming out, but she said, no, I want the treatment because I might get cancer or blah blah blah, then you can start the treatment. But at the same time, you have to tell this is not needed. But at the same time, if they are asking you if she's asymptomatic, what are you going to do? We are going to do nothing, because this is asymptomatic, right? Investigation is bimanual exam, so you have to answer the questions according to what they're asking. It's very important. Read the question, understand, and then write the answer. Investigation by manual exam, CBC, because anemia can occur, ultrasound, sonohysteroscopy, biopsy, and MRI. Treatment is basically if symptomatic, rapidly enlarging on the intracavity, treat anemia, conservative approach, fibroids, absent or minimal, non-submucosal, and currently pregnant. Then what is the medical approach? Basically antiprostaglandin, because NSAID is needed for the pain, or something like ibuprofen or other NSAIDs. Then comes the tranexamic acid, because a lot of bleeding is happening, so you have to give tranexamic acid for to stop the bleeding. Then comes the CHC, IUS, Depo-Provera. You're not going to give all of them. You have to start one by one. CHC, then IUS, then Depo-Provera, whatever is needed. GnRH, Leprolide, but you have to give along with it a combination back therapy. So if you are writing GnRH analog, this is wrong. You have to write GnRH analog along with backup therapy. This is the full answer, okay? Because this is all given along with the backup therapy. Can be used long term to bridge with in the menopause in combination with the back, progesterone, and estrogen. Then comes the alipuracil acetate, which is basically discontinued in Canada, is not used anymore. Interventional radiological approach to UAE, arteries, you can do uterine artery embolization. These can be done as well, but it's usually done in those women who are already completed her childbearing. Then comes surgical approach like myomectomy, hysteroscopic resection, hysterectomy. So you can read all of those. Avoid operating in the fibroid during pregnancy, because what happens due to vascularity and potential, maybe sometimes they give you scenario in the pregnant woman. What are you going to do? You're not going to do anything. You have to wait until the pregnancy is over, then you can do the treatment. Then comes the contraceptives. You need to know the basic contraceptives and their effectiveness. If they ask you the most highly effective one, you need to know which one are those. So these ones, progesterone only, OCP, these are very 99.9%. These other ones are good enough. You have to counsel them to take, use condoms and stuff, but you cannot say this is 100% she will be safe. Then comes the counseling. How will you counsel? This is important. More than 90% of the adolescent pregnancies are unintended, and 50% of all pregnancies occur within first 6 months of initiating sexual activity. In addition, 85% of sexual activity woman becomes pregnant within 1 year. So, you have to counsel the female when she comes for the first, let's suppose if a 16-year-old female came to you in the first time in the clinic, and she were asking you, what are you going to counsel about? You're going to counsel about contraceptives. It's one of the very important things you need to counsel. Okay. And you need to, you don't need to remember all of them. You need to know the effectiveness, how much effective which one are. And then you need to know which one are the pregnancy. Then it's everything is written here. How does it work and how you start it and everything. So you have to remember it by heart. I cannot explain everything one by one. So you need to remember it. COC, how does you put it when you checked it again, when you ask to counsel, what you have to tell that particular patient, what you cannot do in those particular times, and when it started. It's very important, to know the side effects of all the contraceptives, like how side effects of oral is different from IUS, from intradermal, because on the basis of those side effects, you tell the patient, use this one, use that one, use those ones. I have posted one of the question in the group. It says, why not intradermal? What intradermal causes is, it causes obesity. It causes women to gain weight. So a lot of women avoid gaining weight. So that's why intradermal is not the first priority for all of the women. Not all of the women, a lot of the women. Because some women, she says, no, I don't want it because, I particularly don't feel like, gaining weight. So that's why. So you have to keep that thing in your mind that maybe she wants it or not wants it. But if she wants it, I'm okay with it because I'm lean, thin. So if she wants it, you can go for it. Then comes contraceptive ring, and then starting hormonal contraceptives. You can go along with it, and there is no limit when to start contraceptive. So if a female coming with a 13-year-old, you can start a contraceptive. There is no law, so you need to know this is ethically important. You need to know there is no law when to start the contraceptives. Okay, and then you need to know this advantages, side effects, contraceptives by heart. There is no such thing that I have to elaborate here. Still, if it's one of the things that is making me confused when I read it. So this thing, the breast disease, decrease the breast disease and ovarian and endometrial cancer. It decreases it, but at the same time, it says in the contraindication that if somebody is having this problem, you cannot start it. So it is like if somebody is using it and it doesn't have a problem, it decreases it. But if somebody already had the problem, you cannot give the contraceptive. So you need to know what and when and how they are explaining that particular scenario. Okay. So advantages like highly effective, reversible, cycle, dysmenorrhea, benign breast disease, ovarian, endometrial, cervical mucus, PMS, less acne and protection, then side effects, and then contraindications. The contraindications are same here, and then in the menopause. In the menopause is little bit different because you are using in a different way. So yeah, the contraindications, side effects, and these ones are kind of same. I won't say all of them same, but kind of same. Then comes Yasmin and Jazz and tricyclic Elise. These are selected ones. These disadvantages. These are good ones. You can use it if somebody wants it. Why not? So Elise and this one, these all contraindications are already written here. So if you remember these ones, it can apply all over it. So you need, oh yeah, one thing I mentioned here, absolute contraindication is different from the relative ones. So migraines in non-focal with aura, you can use it, right? But a female with migraine with aura means having those numbness, having those other body features like nausea, vomiting, blah blah blah, those features. Migraines with aura, if you go to Google, you will find out what it does, the migraine with focal sorry, with aura and what migraine without aura. You get to know what is the difference. So it is on the basis of that. This sometimes you get confused with this, so you need to know this. Okay. Okay, and then this is on the side, mixed pills, missed pills. Sorry, what happens if you missed one? You can take the next one right away. If you miss more than one, you can take the next right away, and but you need to take any backup contraceptives. But if you miss less than 3 pills in second or third week, you have to take the backup contraceptives right away. You don't miss the 7 day cycle, right? And then in more than three in the second and third, so you have to take the next pill right away, and you have to take the backup contraceptives right away. You cannot take the 7 days off. Then the progesterone only method. Progesterone only method is very like common and it's used. So it is either used in only pill or IUS or Depo-Provera. So it comes in a different one, an Nexplanon, right? Then side on the side, the irregular breakthrough bleeding often occurs in the first few months after starting OCPs, usually resolve after 3 cycles. Progesterone only contraceptives must be taken at the same time every day. So you have to tell that patient that progesterone contraceptive should be taken every time on the same time, sorry, every day on the same time, right? And then you can read all of this from here. It's like the same thing is written: when to remove it, when to put it, when to check it, when to recheck it, when to start it, what is the disadvantages, what is the advantages, because you need to know advantages and disadvantages of individual one. On the basis of that, you can select which one is needed. Then comes the indications, contraindications, side effects. It's important because progesterone is little different from the estrogen and progesterone. Because in estrogen, you have this like thromboembolic diseases and everything, myocardial, but in progesterone you can use that. So you need to remember the estrogen and progesterone contraindications and progesterone indications and contraindications, because those both are different. Okay. Then comes the intrauterine device, copper containing IUS and progesterone. So in the woman with the Wilson disease, you cannot use copper. But if somebody is coming, why not start with a copper? But on the same time, you have to rule out Wilson disease. It's important, right? Then in the side effects, it's not much of the contraindications for them until it's like having a PID, STIs, uterine cavity, post-septic abortion, genital tract bleeding, and pregnancy. I would highly recommend, after reading this topic, go and solve a lot of questions for the contraceptive, because it helps you clear up a lot of your concepts. And if you have any scenario, we can definitely discuss about it. But do solve a lot of questions about contraceptive, because contraceptive is one of the very, very important topic you cannot miss. Then comes emergency postcoital contraceptives, hormonal, which is USP, and then Plan B and alipristal. That is not mostly used, but yeah, still you need to know this is levonorgestrel, this is levonorgestrel, and estradiol. Okay. So, and the contraindications, as I already told you, if you remember the combined ones and the progesterone one, you are good to go. Then comes our postcoital IUD. If somebody's coming with a postcoital and she wants in the 7 days, then you can start with right away as the copper. As if somebody's coming with the copper, and even she's in if somebody's coming after postcoital and she wants a contraceptive as an emergency and she wants something 100% effective, even within 72 hours, I would recommend postcoital IUD copper, not Plan B and USP, because these are less effective as compared to postcoital IUD. As I told you, you need to know the effectiveness. Then follow-up is important, 3 to 4 weeks post-pregnancy to confirm the efficacy, like as she has been already used pregnancy test and contraception counseling. Then comes the termination of the pregnancy. You need to know that, when, at which week, which method should be used. So the medical method, like gold standard up to 9-week gestational age, you can use mifepristone or misoprostol. So those two are used at the 9 week, and 95 to 98% effective up to 49 days. So you can read all of about this, and then you need to know the contraindication when to not use these ones. Basically, when this is a ectopic pregnancy, adrenal, and ambivalence. I'm not reading all of this because this is written what mifepristone do, what misoprostol do, and how they stop it, and blah blah blah. Because this is not like I can explain. You need to read it and get to know by yourself what it is and actually how it is working. And a lot of, like, you don't need to know how mifepristone works on, like, what is their, that pathophysiology and everything. You need to know when to give what. Okay. Then comes the side effect, contraindications between 14 to 24 weeks, and then when to start surgery. Then less than 14 weeks, you start with a vacuum aspiration, and 14 to 24 weeks, you start with a dilation and evacuation. So after 14 weeks, you go for the surgery. But it still depends. If somebody wants to start with the oral, then you can start with the mifepristone and misoprostol, and then start with a vacuum aspiration and wait if she had already terminated, the pregnancies has already been terminated or not. Then comes the rare complications and very rare complications. The very rare complications, like very rare, so you don't need to remember very rare, but you need to know at least the rare complications. And counseling, what are you going to counsel after terminating the pregnancy? It is important. You need to know that, you have to tell her about the next upcoming pregnancy, how she can use contraceptives, future family planning, and ensure follow up and everything, right? Then comes the first and second trimester bleeding. Okay, this spontaneous abortion is important. Threatened, inevitable, incomplete, complete, missed, recurrent, septic. You need to know this table by heart, and by hook and crook, it's gonna ask in any way, either in MCQs or CDMs. This is like kind of important. Management of abortion is always rule out in the ectopic pregnancy. Always check RH, because this is also mentioned in the MCC objective. So you cannot miss those topics which is mentioned in MCC objectives. Management of abortion, always rule out an ectopic pregnancy, always check for the RH if give, and or ROGAM, and ensure patient is hemodynamically stable. So if somebody is coming with abortion with the bleeding, what are you going to do? These are the 3 points you cannot miss. If let's suppose you cannot rule out is threatened, blah blah blah, and you need to rule out the management, you can write these 3. Then comes the threatened, live fetus on the ultrasound and cervix close, in inevitable fetus low in the uterus on ultrasound, cervix close, and residual tissue in the uterus on ultrasound is incomplete, and incomplete, complete uterus on ultrasound, cervix closed, and no bleeding. No fetal heart rate on ultrasound, fetus and sac still in the uterus, and cervix closed, and no bleeding. Then management, each management stage, first of all, you need to do is watch and wait, and then misoprostol. Then comes to the dilation and curettage. In each of them, you need to do the same. But in the mist, you need to give misoprostol followed by mifepristone followed by misoprostol. In the other ones, you need to give wait and watch and wait, and then give misoprostol. Then in the septic one, you need to start with antibiotics, dilatation and curettage, and the misoprostol. Then comes ectopic pregnancy. Ectopic pregnancy, you need to know the points where it is located at where point. So like its most common site is basically ampullary, 70%. Then istimal, then femoral, ovarian, interstitial, and abdominal. Then here, this is the topic, this is the point table which will cover the whole topic. If that person is coming, what are you going to do first? What are you going to do first is basically beta hcg. You need to rule out if she's pregnant or not. Then if she is pregnant and abdominal pain and she is having bleeding, you need to think of this as ectopic pregnancy until proven otherwise. Then comes the, you need to check if that patient is hemodynamically stable or unstable. If she's unstable, then definitely go for surgery right away, because you need to save the patient. But if she is stable, you need to start from the conservative treatment, doing transvaginal ultrasound. You find that uterus is empty, then you do serum beta hcg. Maybe serum beta hcg is coming down, and the baby then the already termination of the pregnancy is started. But if it's not happening, then what you do? So it comes in a different presentation. Transvaginal ultrasound, it is basically intrauterine pregnancy. Then nothing, wait and watch, do nothing. Then comes if beta hcg level low and declining, no fetal heart rate, maybe the termination of pregnancy is already needed. Already started. So what you can do is expectant management, wait and watch and wait. If needed, misoprostol, and then keep on follow up. Then comes maybe less than 3.5 centimeter, unruptured ectopic, and no fetal heart rate, beta hcg less than 5,000, no hepatic, renal, hematological disease, compliance assurance, and able to. So you need to know all of this before starting methotrexate. You need to confirm that patient will do all of this, and you need to rule out the contraindications. The contraindications are written on the side before giving methotrexate. And then patient does not meet the criteria, then what are you going to do? Because if she cannot take methotrexate, you need to do something, right? So go for surgery. So what are the contraindications? I remember methotrexate's contraindications, because methotrexate is affecting everywhere: hematological, hepatic, renal, pulmonary, GI. immunodeficiency, hypersensitivity. So it is affecting everywhere. So you need to remember, because methotrexate is very important here in SLE. So not an SLE, as in rheumatoid arthritis and everything. So it's uses over there as well. So now comes the risk factors you need to know. Maybe IUD, PID, infertility, previous procedures, smoking, and then structural, and then adhesions, leiomyoma. Then you do investigation. What are those investigation? Beta HCG, ultrasound, suspected ectopic pregnancy, and laparoscopy. Gold standard is basically conservative, maintain hemodynamic stability, and laparoscopy, and then methotrexate. So you need to rule out. So you need to read everything from here. So just to go through quickly, because I cannot read it quickly because of the short of the time. So it's very important. So you need to read everything. Why methotrexate? What is the contraindication? What are the indications? Plateau, and then persistent trophoblastic tissue further present. Then what are you going to do next? Prenatal, because when you are giving methotrexate, what you need to do is, if she's taking folic acid, you have to stop folic acid, because their pathology or their mechanism of action, methotrexate, is kind of linked to the folic acid. So what happens is, if she's taking folic acid, the efficacy of methotrexate becomes lower. So you need to know that she stops taking folic acid, then you can give methotrexate. Expected management is option, and which is, if she's stable, you might need to wait and watch, and then wait, maybe she already pass out all those retained products of placenta. Then prognosis, 9% maybe died, and 60% in the pregnancy, again after surgery, and 10 to 20% subsequent ectopic pregnancy. So if somebody already had ectopic pregnancy, might have an ectopic pregnancy again. So risk factors are very, very important. PID, IUD. So if somebody is having PID, might have ectopic pregnancy. So this is very important. Then, as I already told you, differential diagnosis are important, as infection could be the one of the main differential diagnosis. Anywhere infection, UTI, appendicitis, diverticulitis, endometriosis. Anyone presenting with abdominal pain, vaginal bleeding, and amenorrhea as ectopic pregnancy until proven otherwise. Very, very important. Until proven otherwise are the statements that is already applied. So more than half of the patient with ectopic pregnancy have no risk factors, and presentation acute abdomen with the increasing pain, abdominal distension, and shock. So I'm going to stop here for today. And just a second.